Disclosures. This is a picture. Some of these guys get brachytherapy, especially in the early days, they really got into it. I mean, one guy had a tattoo of Bugs Bunny on his leg, so he went up in stirrups because he knew there was going to be 30 docs watching the procedure. He had Bugs Bunny on his tattoo, permanently in color, coming out of his legs, holding radioactive seeds. And this guy's more reasonable. He made a shirt. So I discussed a little bit the history, dose conformality, teamwork. I think teamwork's very important. I think it's one of the advantages of brachytherapy, not only all the good results you've already heard from Dr. Stock and Stone, but also that you're working with urologists, usually together in the OR, and you get a lot of benefits from doing that. We'll talk about low risk, favorable, intermediate, high risk, very high risk, and androgen ablation therapy in high risk patients. But first of all, for the urologists out there, one of you guys, who is Hugh Hampton Young and what is he famous for? For radiation oncology, anybody? How about Alexander? Okay, he was the head of Johns Hopkins surgery and is famous for developing the radical prostatectomy. So a pretty famous guy. Turn of the century, like 1902 or so, 1904, he did the first radical prostatectomy. So that's what he's well known for. But did you know he only did 26 radical prostatectomies in his whole career? He did over 500 patients with brachytherapy. So it's been around a long time. And that was intraurethral radiation they did through a cystoscope. But they were in the perineal position in stirrups, and it looks very similar to what we did now in terms of the way the patient's positioned. Now then move on to the present. You go to Memorial Sloan Kettering doing the open implants. And when they had a good quality implant, which was less than half the time, the results were better than external beam or better than surgery, but it fell out of favor because they couldn't do it that often. So when Ragda came over, he's our urologist in Seattle, came over from Denmark after seeing Holm do this new ultrasound, transrectal ultrasound to biopsy patients. He thought, well, this would be exciting. I can use ultrasound and do like prostate screening, and it'd be the new mammogram for men, basically. And thinking we'd biopsy the hypoechoic focus. But then he said he also saw Holm do these implants, put the radioactive seeds in transperineally with this old-fashioned, only transverse image, and it was like a radar thing that went around, and you had a ghost of the image would fade between each sweep, and so he did a few implants with Blasco, like November of 1986. They did a few more in 87 with Blasco and Grimm. I came in 86, 87 I came there. And then the ultrasound equipment started getting better, and we started doing the seeds. But unlike Holm, what we did is Holm gave too high of a dose of radiation beam and did the seeds like right before the beam, and it just overdosed guys. And he didn't have a template or anything like that. So we used the SIAD technique for doing iridium implants with a template, and we separated the beam and the seeds, did the beam first, followed by the seeds at that point, and gave a lower dose of the beam. He was going 2.5 gray to 47.5 gray right after the seeds were put in, like 2 weeks after the seeds were put in. So those guys got a lot of dose. So we changed things around. And and we had a lot of Boeing engineers that thought this is really cool stuff, and they wanted to do this. It was in Seattle, and that's kind of how the brachytherapy thing started in Seattle. Now, as far as radiation, when you do IMRT, you're giving this low-dose bath of radiation to the whole pelvis or the whole, prostate and beyond that is totally unnecessary in terms of curing the cancer. And so you can see the yellow is kind of a moderate dose, and the rectum's in part of the yellow there. And the skin, as you can see, gets very low dose. It gets virtually no dose. So that's why guys with prostate radiation don't really get any skin reaction at all. Brachytherapy, of course, is putting the radioactive element right in the prostate. So you're not going through this normal tissue. And this is HDR or LDR similar. You're not really giving this bath of radiation everywhere. And there's a better picture here. So it shows a standard IMRT over here, giving a large area of radiation, 50% of the dose to tissue doesn't need it. Protons gives significant dose to the hips and beyond the prostate as well, while the brachytherapy, be LDR or HDR, is very tight. Now, in terms of low-risk disease, we don't usually treat a lot of low-risk disease now, but we do see some because guys go on active surveillance, and then, the PSA starts going up, or they have a higher volume of cores that are biopsy positive, so we do still see those guys. And probably those guys we're seeing now are much more favorable than the guys we saw in the past with de novo, 9 biopsies of Gleason 6 and whatnot. But being that as it is, the data from Memorial Sloan Kettering from years ago showed 7-year relapse-free survival of 97%. Patients we treated over, almost a quarter century ago now, it was 99%. So that's pretty good for low-risk disease with a single outpatient treatment. By comparison, modern radical prostatectomy and modern IMRT is lower. They have more favorable disease, and modern prostatectomy obviously fails because they're missing extracapsular extension, microscopic disease, which is common even in low-risk patients, certainly very common in intermediate and high-risk patients. And the IMRT is failing because of the BED, the dose is low. And, the flame approach may help take care of some of that, and I'm certainly doing some of that myself. But bottom line, for most patients, it's a lower dose, so it doesn't always sterilize everything inside the prostate. So Peter Grimm and I published this in 2009, and then when I left Seattle in 2010, he updated it in 2012. And a lot of the patients that go on the internet, they may find this on various websites. But basically what we did is we collaborated with about 20 radiation oncologists from around the world, and surgeons, and pathologists, and medical oncologists that specialize in prostate cancer. We came up with this criteria for a study to be considered a good study, and therefore go on this comparative effectiveness analysis approach. They had to be published in a peer-reviewed journal. Couldn't just be an abstract or something they say at a meeting. And it had to have at least 100 patients and at least 5 years of follow-up. And that was basically the criteria for that to get into this chart. And for low-risk guys, you can see pretty much anything works pretty well. There's a lot of overlap here. But overall, you do see a little bit of a downward trend with surgery, a little bit of a downward trend with external beam radiation, and the brachytherapy is pretty straight, horizontal. You don't see a lot of failures. And they have also more studies with brachytherapy and longer follow-up with brachytherapy. When you get to intermediate risk, well, as you would expect, surgery would start failing more often because they have a higher risk of extracapsular extension. Just basic fact. Parton table has shown that. Other people have reproduced that. The external beam, you got worse disease. You need to really sterilize it, and they're still limited. Now, some of these lower, now this is 40% here, so it goes down zeros way down here. Some of these lower boxes here on external beam, these green boxes, are doses we don't use anymore. These are like 75 gray or 72 gray. It had to be 72 gray or higher to make the studies. So I'd ignore these ones down here. So the IMRT is kind of in this area here. You see brachytherapy and external beam are the black triangles, and seed implant monotherapy are the blue dots, and HDR here is mainly combined with external beam. There's a lot of variation in the seed monotherapy, doing poorly versus doing very well. And we don't have the dosimetry on a lot of these papers, but I certainly assume that most of these guys down here had poor quality implants. Later on, the RTOG did a randomized trial for favorable intermediate risk patients, and they randomized them to external beam and brachytherapy versus brachytherapy monotherapy. And for favorable intermediate risk patients, the randomized trial showed clearly that the cure rates were the same with brachytherapy monotherapy as combination, but the side effects were less. So as long as you do good and it was a good high quality implant, multiple institutions, and shows that for favorable intermediate risk, you really don't have to do combination therapy. And the NCCN guidelines, I believe, will change that pretty soon and allow that to be considered for unfavorable intermediate risk. I mean, some of us are doing some of that already now anyway. So one study on long-term outcomes of LDR brachytherapy compared to hypofractionated external beam was again a multi-institutional study, and they compared the patients treated with LDR monotherapy versus hypofractionated external beam to 60 gray and 20 fractions, which is kind of the standard international approach. In the U.S., it's usually 28 fractions times 2.5. I don't think it would have anything to do with reimbursement, but that's what the U.S. does. And what you see is at 7.5 years, the relapse-free survival is significantly better with the brachytherapy. Metastatic disease-free survival also significantly better with brachytherapy compared to hypofractionated external beam. And cancer-specific survival at 8 years, there's very few deaths in either arm. Maybe a little bit of a trend, but probably not enough patients to show it in the long run. So locum control is important, though, and that's where you get to distant metastatic disease-free survival. And if you look at the risk for distant metastasis, as you have local failure, your risk for mets go up. And again, you want to knock out that first wave of distant metastasis. So while you can say you can treat a patient with IMRT, and if they fail, then you can do brachy salvage, or you do surgery and they fail surgery, you can do external beam salvage. You got to worry about these patients you're going to lose to metastatic disease during the interim. So the ASCEND trial you've already heard a lot about. I'll just give you a little bit, they went both Stock and Stone went over this very well, but a little bit of the history of this. Jim Morris, who was the lead author of that, he's in Vancouver, British Columbia, and he used to come down to our offices in Seattle frequently. All those guys did, because we're only 2 hours apart by car. And they were really frustrated, because in Canada at that time, you only could do brachytherapy on patients that had low risk and favorable intermediate risk patients. You only do brachytherapy monotherapy, but they know from our data and the data from Stock and Stone and others that really is the unfavorable intermediate risk and high risk patients that really benefit the most from brachytherapy. So they were being frustrated, so they said, okay, I'm going to do this study, and that way at least we know half of our patients will get brachytherapy. Plus, it'll just be a good study to do to prove to Canada that that combination therapy has better outcomes than external beam without brachytherapy. So you've already seen some of this. The 10-year update showed 85% relapse-free survival versus 67% with the addition of brachytherapy versus no brachytherapy. No difference in distant metastatic disease-free survival statistically, although rough numbers looks pretty interesting, and no difference in overall survival. This is the issue that Nelson brought up, the grade 3 toxicity, 19% in the LDR arm. Now, no other study has ever shown anything close to that with brachytherapy. They had about 50% of these were urethral strictures that were dilated once or twice, and then the patients were fine after that, actually. But again, this is the initial experience with them doing combination therapy. They'd never done it before. They had multiple centers involved, and we don't have any post-op dosimetry, but I highly suspect they got pretty high doses to the urethra, especially at the apex, I think, is where they had most of their issue. So, bottom line, with the ASCENDE-RT trial, clearly the cure rates were better, but the rate of geotoxicity is an excuse a lot of people use to say no brachytherapy for prostate cancer. You're going to stick with external beam. And also the overall survival wasn't different. So what happened is then in British Columbia, they did a randomized trial of the same external beam dose, and they randomized patients to HDR versus LDR boost. And they saw a much lower grade 3 toxicity rate with more modern patients they're treating. So this is a study, Dr. Crook and Cheng were the primary authors. It was in British Columbia where this all started with their ASCENDE-RT trial. And again, they got the 46 gray and 23 fractions. They got the hormone therapy, so very similar to the ASCENDE-RT trial. The difference was basically just more experienced doctors doing the implants. They did HDR in 1 fraction or LDR boost, very standard doses. And because some people have talked about, well, maybe HDR has less side effects than LDR, and we didn't see that in our practice, but others have suggested that. It was well-matched group of patients with unfavorable and high-risk patients in both arms. And so what we found is the HDR patients' epic urinary function, IPSS scores, came back to baseline within 6 months. LDR took longer to recover, it took 18 months. Although acutely, the HDR had worse urinary side effects because it was more of a peak dose and went down faster in terms of side effects, while LDR was It didn't go up quite as high on intensity of urinary side effects, but took longer to go down. But bottom line, 18 to 60 months, there's no difference in toxicity between LDR and HDR. And in terms of grade 3 toxicities, there was only one grade 3 GU toxicity in each arm. So not 19%. You're talking, 1% or less. There was, in terms of grade 2, there was 6.7% in HDR and 2.4% in the LDR. That's not statistically significantly different. So the bottom line is the HDR, LDR boost, equally reasonable. But the grade 3 toxicities just aren't there in any study, basically, except for that one ASCENDE-RT trial. Biochemical failure outcomes are the same. Although this study really was primarily focused on quality of life issues. The people that failed primarily were distant only was a primary failure rate. Local failure was rare alone. Local plus regional, rare. So the brachytherapy combination with external beam clearly has extremely good local control rates. So insufficient numbers in terms of efficacy. Basically, the main thing is that biochemical relapse-free survival is similar at 5 and 8 years. Quality of life is the same, and that either HDR or LDR boost are quite reasonable. Now, as far as high-risk patients go, again, that same slide, and as expected, the surgical data really takes a dive here. Kind of drives me a little crazy. I get all these patients they call from out of state and out of my region saying they were told by their surgeon they can't have brachytherapy because they have high-risk disease. They got to have surgery because it's aggressive. They got to do radical treatment. Or they see the radiation oncologist and say, well, brachytherapy is only good for low-risk disease. You got to do external beam and 2 years of hormones. Well, the data clearly doesn't show that. Combination external beam plus brachytherapy, the black stars, horizontal is not dropping down with time. Surgery is dropping down with time, quite low, and external beam without, again, ignore these lower ones because these are lower doses of radiation we don't use anymore, are not doing as well either. And certainly don't have the long follow-up. Now, this is something that kind of perplexed us for the last decade or so, and I'll get to the TRIP trial again, which was a great study that was done in Japan. And we have a lot of overlap here with the diamonds, which is external beam hormones and seeds, versus the stars, which is external beam and seeds without the hormones. These are not randomized. Each one's a different study here. And so some people look at this and say, well, there's a lot of overlap there. The hormones aren't doing you any good. And other people will say, well, in my practice, I only give the hormones to guys with really bad high-risk disease. And if they have really minimal high-risk disease, I don't give the hormones. So the fact that the hormone group is doing as well as the beam and seeds suggests that maybe the hormones is doing something. So there's no answer to that until you get a randomized trial, which we have now. But before we do that, let's talk about very high-risk disease. So again, this was discussed already, but it was a huge study in JAMA by Keishan et al., 12 major academic centers. Now, what was interesting is that the GU ASCO in Orlando about 9 or 10 years ago, they presented this in a poster session. It was only 2 centers. It was UCLA and University of Pennsylvania, and it showed, and the urologist published it there in the poster format, and it showed the results of showing the brachytherapy was doing so great compared to everything else, and then it disappeared. You couldn't find anything. Then Keishan went and contacted everybody else, and Mount Sinai and got 12 centers and made it so large that nobody could ignore it. So then he went ahead and published the outcomes. And so again, Dr. Stock, of course, is in here. A lot of different centers and Cleveland Clinic, et cetera. Huge study of Gleason 9 and 10 cancer. There's no randomized trials for Gleason 9 and 10 specifically, but if you got to do a retrospective review, I can't imagine having a better one than this with all these major centers. And distant metastatic disease-free survival. Huge difference with the addition of brachytherapy versus no brachytherapy. A patient see that and they immediately say, I want brachytherapy. I had 2 guys this week, Gleason 9 cancers, call me up. One guy's South Carolina, my age, IT guy, and he was told by his urologist up there he had to have surgery. His radiation oncologist, he's got to do external beam and hormones. Another guy was a doctor down at the University of Miami, and he was told by the surgeon he's got to have surgery. He was told by the radiation oncologist you got to have radiation and hormones. And then he went to a well-known urologist in Celebration, Florida, who said, "Oh no, I'm going to give you Orgovix. You're going to stay on that for several months and then under surgery." And he'd seen this. He actually went to the Prostate Cancer Research Institute website with Mark Schultz in LA, who's got a big website presence that educates patients, and they learn all this stuff with the little YouTube videos that are pretty darn accurate. Prostate cancer specific survival, obviously much better, and even overall survival was better. I mean, overall survival comes together. Everybody dies eventually of something, but you know, it's impressive to have an overall survival difference in prostate cancer. So brachytherapy boost, clearly better local control rates, probably decreases the risk of secondary wave of distant metastatic disease, and in the very high-risk patients, we're starting to see some survival outcomes. And as far as androgen ablation goes in LDR brachytherapy patients, this was already, Dr. Stone went over this in good detail. Like to just point out that you know, they had a significant number of high-risk patients. They were all high-risk patients. They all got external beam and brachytherapy to very standard doses, and the numbers were well balanced on both sides. They had a significant percentage of patients had multiple risk factors as well. 43% had multiple high-risk factors, and follow-up was excellent. And you saw that testosterone recovery. If you got 6 months of hormone therapy, the testosterone recovery occurred in 72% of men. But if you had the 30 months of hormone therapy, it was only 43% had testosterone recovery. So it makes a big difference in terms of quality of life there. But there was no difference in cure rates. So why do all that extra hormone therapy when you have the excess toxicity without the benefit? So I think, you know, this study shows that 6 months was equal to 30 months. Testosterone recovery was better in the 6 months. And I think it suggests that 6 months is like the maximum amount of ADT you need. And we don't even know if you need a full 6 months, because trying to do, you know, 0 versus 30 months, we tried to do that. And it was Dr. Merrick and myself and Kent Wallner wrote a study for high-risk patients with no hormones or hormones, and we had it open for 3 years. We got 5 patients to sign up for the study because no one wanted to be randomized to hormones and no hormones. Either didn't want it or they definitely wanted it, but nobody wanted to be randomized, so we had to give up on it. So the advantages of brachytherapy: highest progression-free survival of any treatment in any risk group, even after you calculate salvage IMRT after radical prostatectomy failures. Highest overall survival, distant metastatic disease-free survival, prostate cancer-specific survival, and high-grade disease. It's got a better distant metastatic disease-free survival in unfavorable intermediate-risk patients compared to hypofractionated external beam radiation. Quick outpatient treatment similar to transperineal biopsies. Low risk of incontinence. You only need 6 months of hormones in high-risk patients. Remember, about 19 to 20% of the patients in the TRIP trial had Gleason 9 and 10 disease. And it's teamwork. You're working together with urologists in the OR, and when that happens, you discuss other cases you're going to deal with, and you just have better communication, which is better for the patients. So, you know, really brachytherapy is the ultimate in adaptive radiation therapy. You talked about adaptive radiation therapy, the external beam. When the OR, you're seeing where you're putting the seeds, and the prostate, you know, moves around. Well, you move your needle around. You can take care of that. It's the ultimate in being conformal, where you're not treating normal tissue to a higher dose than you need, and it's the ultimate dose to the prostate. And if you want to give a little higher dose to the DIL, you could do that. And it's cheaper than the other things, which is probably why we don't do it anymore here in the States. But in Canada and Europe, they do a lot of it. So this was at the ABS, a woman talking about cervical cancer from Africa, and said, if you want to go fast, go it alone. So you can do your beam alone somewhere if you want, your surgery alone. But if you do teamwork, if you want to go far, you go together. So, you know, radiation oncology and urologists working together, that's brachytherapy. Thanks.